Hi, Dr. Leong here. Can I just check that you hear me loud and clear?
All right. Without further ado, I will begin since it's 6:55 and it's 5 minutes to 7 p.m. Good evening, ladies and gentlemen. Welcome to the Beyond Webinar Series Webinar 2, entitled APAC Vaccination Climate and Perspectives. We will begin shortly at 7 p.m. In the meantime, I will be your MC Rustam, and I'll be going through with you the introduction. So please bear with me. Before we begin, I'd like to give a brief reminder to all Beyond participants that today is the final deadline of submission for your confirmed problem statement, which is due at GMT +8:12 midnight, which is about in 5 hours time. So from my understanding, we still have a few groups who still have not submitted their final problem statement. So should you be one of those groups, please do so within 5 hours time. And you can do so by contacting the Beyond team about your selection via WhatsApp, Facebook, or email. Now, my fellow participants, we are 1 week away from the preliminaries of the Beyond Health Hack, which will be organized on the 7th of August. As you may have noticed, this hackathon has a stronger nexus of focus in the Asia-Pacific arena. However, most medical and pharmacy students are not equipped with the pertinent knowledge about the regulations, the processes, as well as the current situation of vaccination. Hence, we have brought in a slew of speakers to educate you on just that. A full disclaimer, this webinar session is actually quite heavy. We will be introducing many different elements of thinking, and I encourage you to ask as many questions as possible. But first, let me first talk about the format of today's webinar session. Now, today's webinar session will have 3 information sessions back to back, followed by a moderated panel discussion that will be facilitated by Mr. Jackson Lim. To talk more about the esteemed speakers and panelists. Hold on. Yes, these will be our 3 speakers, which are Mr. Kim Sampson, Dr. Yolanda Roble, as well as Dr. Leong Ho Nam. Now, to talk more about these people, I will first start with Mr. Kim Sampson, our first speaker. Now, Mr. Kim is the Chief Executive Officer of the Australian Immunization Coalition and their company secretary, as well as the Executive Director of the APACI, the Asia Pacific Alliance for the Control of Influenza. Mr. Kim has worked in science and medical administration for over 35 years, and while his earlier career was in the neurosciences, for the past 12 years, he has been working in infectious diseases with a particular focus on influenza. Mr. Kim is also the president of the Australia-Vietnam Friendship Society. Now, for our second speaker of the night, we will have Professor Yolanda R. Roble. Now, Dr. Yolanda is the immediate past president of the Philippine Pharmacists Association and has served the organization for the last 16 years in various capacities. She served as the Dean of the University of the Philippines College of Pharmacy for 2 terms, 6 years in total. And she is currently a professor at the UP College of Pharmacy and is serving in the Asian region in her capacity as president-elect of the Federation of Asian Pharmaceutical Associations. Previously, she was the president of 2 pharmacy associations, and for Dr. Roble's research area, she mainly contributes in the area of health policy, pharmacy practice, and education. So her speech will revolve around that topic as well. Now, for our last speaker will be Dr. Leong Ho Nam. He is an infectious disease physician in the private practice, passionate on education and vaccination. He was a graduate of NUS Medicine and has been specializing in infectious diseases since 2000. Now, this is just a brief recap on the format, as we will first be having 3 information sessions by our speakers, followed by a panel discussion. And during that info session, you can pose your question to all 3 of the speakers or even pose them directly to one speaker. This panel discussion will be moderated by Mr. Jackson Lim. Now, Mr. Jack is a self-professed evangelist for the pharmacy profession and its vital place in the health system. He sincerely believes that pharmacists are key in creating healthier, happier communities. He's a community pharmacist at TGAS Alliance Pharmacies with varied work experience, having previously served in hospital, manufacturing, and industry. He is also the founding president of the Asian Young Pharmacists Group. Helping out the background is the Beyond team, who will be facilitating the event and the live streaming of such questions. I will be your MC for tonight. My name is Rustam, and this is our team that will be working behind the scenes. We have Musa, who will be our publicity head, Junqi, who will be our vice publicity head, and Ti Huang, who will be our technical lead for the night. Now, without further ado, I would like to hand over the floor to Mr. Kim to talk more on policy. Mr. Kim, can I check if you're ready?
Yes, I am ready. Thank you.
I will stop sharing my screen first, and the floor will be yours. Please turn on your camera if possible, and then we will proceed from there.
Okay, so thank you for the invitation to speak at this very important event. Look, the things I want to cover today are about understanding the process of policy implementation. We need to understand global burden of disease. We need to consider the WHO recommendations on risk groups. The WHO surveys we can look at in terms of the tropical and subtropical regions, the role of PIVI, countries with national immunisation schedules, and influenza vaccine uptake in the Asia Pacific region. And then finally, we'll look at the steps for policy making. Now, all of you, I am sure, know these numbers. The WHO estimates that each year seasonal influenza epidemics cause between 3 to 5 million cases and up to 650,000 deaths globally. Of course, this year is very unusual because we have a pandemic, which all the strategies we're using to battle that pandemic are actually seeing flu numbers fall dramatically. The WHO had made some recommendations back in 2012, and the Strategy Advisory Group of Experts, or SAGE as they are referred to, on immunisation was established by the Director General of the World Health Organization in 1999 to provide guidance on the work of the WHO. The SAGE advises the WHO on overall global policies and strategies, ranging from vaccines and technology to research and development and delivery of immunisation. So in 2012, priority groups were introduced for countries using or considering using or introducing a seasonal influenza vaccination program. And so the highest priority group were pregnant women, and that came out as a result of the 2009 swine flu pandemic, where we saw huge numbers of pregnant women being adversely affected by that pandemic. And then, of course, children, particularly those under 5 years of age, the elderly, healthcare workers, people with underlying health conditions. And in Australia, we actually had recommendations, although it's not part of our program, but we recommend smokers and people suffering from obesity should also be vaccinated against influenza. So this particular slide is showing, the entire globe, and I really just want to focus on the Asia Pacific area. But this WHO survey on influenza immunisation policy in tropical and subtropical countries was put together a number of years ago, but is still valid today. So in an effort to strengthen the collaboration and minimise the reporting burden, the WHO and UNICEF jointly collect information through a standard questionnaire, which is sent to all member states. The information collected in this joint reporting form include estimates of national immunisation coverage, reported cases of vaccine-preventable diseases, immunisation schedules, as well as indicators of immunisation system performance. And so the data showed that 64% or 64 of the 138 countries and territories, or 46%, did have a national vaccination policy for influenza, for seasonal influenza. 18 countries, comprising 93% of the population of the Western Pacific region, had established policies for seasonal influenza vaccination. 7 countries recommended influenza vaccination for high-risk groups. And countries in the Asia Pacific that have no policy for seasonal influenza vaccination include Bangladesh, India, Cambodia, North Korea, Laos, and China. But I put an asterisk against China because that is evolving. So China has an ongoing development of influenza vaccination policy, and APAC, one of the organizations I work with, have been doing a lot of work with the China CDC and the Chinese Preventative Medicine Association to look at how influenza vaccination policy could be implemented. But at the moment, influenza vaccine is a category 2 vaccine in China. It means that vaccination is voluntary, recipients do need to pay, but Beijing does provide free vaccine, and this is the Beijing province, to over 60s, some school-age children. There are recommendations for points of vaccination clinics to enable influenza vaccination for people 6 months and over that are willing to be vaccinated and that they have no contraindications. And currently, China has licensed both trivalent and quadrivalent inactivated influenza vaccines. So the Partnership for Influenza Vaccine Introduction, or PIVI as it is known, it's a key program of the Task Force for Global Health, which is part of the WHO, and it's working with UNICEF, the Rockefeller Foundation, the World Bank, and the United Nations Development Program. Its mission is to reduce the global disease burden from influenza and improve national and global responses to pandemics and other epidemic threats. It will achieve this through the development of sustainable influenza vaccination programs in low and middle income countries. It works in partnership with the Centers for Disease Control and Prevention, the CDCs, the Ministries of Health, and other corporate partners. So, as most of you would know, or I'm sure all of you know, that there are 2 vaccine formulas that are developed, one for the Northern Hemisphere, one for the Southern Hemisphere. And so historically, countries in the tropics selected the WHO recommendation according to the Northern Hemisphere or Southern Hemisphere, largely based on whether they were situated north or south of the equator. And they timed their vaccination campaigns accordingly, irrespective of the timing of the influenza epidemics in their country. This is a really important point because not all flu seasons are the same, and not all countries have the same kind of or same timing of their flu season. In fact, some countries have 2 peaks, but nevertheless, recent evidence indicated that in many such instances, the vaccination campaign occurred too late to cover the influenza season or too early to offer optimal protection for the upcoming influenza season. So in this map, you can see that Thailand and Malaysia, for example, are both using Southern Hemisphere vaccines, although they are certainly in the north of the equator. And so what we see now is that vaccination campaigns in many of the tropical countries in both hemispheres, where peak influenza activity frequently coincides with the rainy season, campaigns are timed with the availability of the Southern Hemisphere vaccine formulation. And you have situations where countries like Singapore, in fact, might switch from the north to the south. So another survey undertaken by the WHO Western Pacific region, the Surveillance and Response Survey, and at the time of collecting this data, there were 18 countries within the region that included seasonal influenza vaccination in their national immunisation schedules. And they include Australia and New Zealand, Malaysia and Mongolia, amongst others. And I just wanted to provide a comparison of 2 countries, one of them being Australia and the other Mongolia. Excuse me. In Australia, the aim of the Australian immunisation policy is to prevent disease and severe outcomes of disease by maximising immunisation coverage in people of all ages. So we have a national immunisation program which includes influenza, amongst other vaccines, and it is recommended for all people 6 months and older. However, it is fully funded for certain risk groups, and they are pregnant women, children aged less than 5 years, people aged 65 and over, Indigenous people aged 6 months and older, and people with underlying medical conditions. In Mongolia, however, influenza vaccination is voluntary based with a payment. The target risk groups for flu vaccines are issued by the Ministry of Health, and they will, and currently the risk groups are identified as children aged less than 5 years, elderly and people with underlying health conditions, healthcare workers, and other staff that fall into the emergency agencies such as the police, army, etc. And in the future, pregnant women are under consideration according to the WHO list of priority groups. Of the 18 countries that responded to that surveillance and response survey, all included healthcare workers and the elderly. However, there is a growing trend to include young children and pregnant women, and you can see on this list here that 100% of those countries that I mentioned include healthcare workers and the elderly, and you can see that to a lesser degree, they include pregnant women and those with high risk conditions, and least of all, children under 5 years of age. Funding of influenza vaccination in national immunisation schedules in the Western Pacific region is very mixed, although public funding occurs in varying degrees to a majority of the countries participating in that survey. And they include Australia, New Zealand, South Korea, and to a lesser degree, China, Japan, and the Philippines. A public funded vaccination program, such as in Australia, means that the government purchases the vaccine on behalf of the community, and it is given to those considered most at risk. A privately funded program, however, means that members of the community must pay for the vaccine. In some cases, it may be a private and public mix, whereby the government will subsidise the cost to some extent. In the case of Australia, those that are not covered by the public program are free to purchase the vaccine and have it administered by an appropriate immunisation provider. The information in this particular graph is a little outdated, as Australia is now providing enough vaccine to vaccinise, enough influenza vaccine to immunise over 60% of the population, compared to around 20% shown on this particular graph. But you can see that there is a wide disparity between the percentage of the population that are provided with the vaccine or given the opportunity to be vaccinated. This particular slide talks about the steps for policy making and the introduction of an influenza vaccine. So we start at the bottom of the stairs on the left-hand side of that image, and we can see that understanding the burden of disease, using surveillance for morbidity and mortality, and knowing the size of the risk groups and of the clinical impact of the disease are critical for moving further up that stairway. Next, we need to understand vaccine safety and efficacy, its cost and its acceptability. We need to understand cost effectiveness, and that is understanding the financial dynamics and effectiveness of introducing a vaccine. We know we must understand the risk groups and the public health priorities, having undertaken the risk-benefit analysis, which falls into the priority decision making. And then there's financing a program, the health economics of the public health intervention, and understanding the issues around introducing a program and to ensure that the public are actually on side with the idea. The vaccine supply issues and the infrastructure for a vaccination program has to be in place. And the ultimate goal of a policy decision through an advisory group under the Ministry of Health or equivalent for implementation. And here we're talking about the ministries or whatever other body is responsible for the introduction. So recommendations for seasonal influenza vaccination from the WHO, the Southeastern and Southeast Asia Regional Immunisation Technical Advisory Group. The countries in the region should develop national policies on seasonal influenza vaccination for high-risk groups: pregnant women, children aged up to 5 years of age, the elderly, individuals with underlying medical conditions, and for healthcare workers. The recommendation is that all countries in the region should develop plans for generating evidence or collating existing evidence for decision-making. All countries should strengthen influenza surveillance, establish disease burden, and share data with the WHO regional office. And seasonal influenza, this is the last slide really, seasonal influenza vaccination and pandemic preparedness. This is a really important aspect. Seasonal influenza vaccination program creates a critical infrastructure. The ability to roll out an influenza vaccination program during a pandemic is critical. So if we establish a vaccination program in a country, we have the infrastructure in place to roll out a vaccine should a pandemic come about, as very much as we have right now. So a seasonal influenza vaccination program does more than protect citizens from seasonal influenza. It prepares the country for dealing with a pandemic. And I'd like to thank you for your attention. Thank you. Bye.
I apologize. Okay, I'll just like to reiterate what I said just now. Thank you so much, Mr. King. I apologize for having my mic turned off. Now, without further ado, I'd like to hand over the stage to Professor Yolanda. Now, just to give a reminder to all of our viewers that we will be having a question session at the end, at the second half of our webinar session. But in the meantime, we will first be having 3 presentations back to back. And to just give a bit more context of the next speaker, she will be presenting more about the Philippines as well as their journey in implementing a new act in their constitution which allow pharmacists to be able to vaccinate within the Philippines as well, which is quite exciting. And within the Asia Pacific arena is actually one of the newest developments as well. So without further ado, I'd like to hand over the stage to Professor Yolanda.
Thank you, Rustam. Good evening, everyone, and I'm happy to share with you our experience in the Philippines. And so this is entitled Pharmacist Vaccination Efforts in the Asia Pacific, the Philippine Experience. So this will be the outline of discussion. I will be first mentioning about a bit of background, and then we'll go to the policy framework, and we'll be enumerating the different stakeholders that took part in the policy making, and I will speak some on what we did on the training. With regards to implementation, partially yes, and then we will conclude it. Now, just to give you a bit of background about the Philippine Pharmacists Association, we are the mother organization of 10 affiliate organizations and 88 geographically distributed local chapters. We are accredited by the Professional Regulation Commission as the accredited integrated professional organization for pharmacists, which represents pharmacists in the different regulatory bodies and in representing them in different issues. So we have a current membership of more than 25,000 registered pharmacists, but this will improve as this year, given that our role as accredited integrated professional organization makes it mandatory for all pharmacists registered in the Philippines to be a member of our organization. And you could see here a listing of the different organizations representing the different practice areas. So you have their hospital, those in the industry, in the community, and then we have those in the colleges, the educators, those employed in the government, those employed in cosmetics, health and wellness, and veterinary, and even young pharmacist group is considered. And we have the youngest group, and that's the Federation of Junior Chapters of PPHA, which are pharmacy students from all the different schools of pharmacy. So as you can see, globally, our role had expanded to include population-based care. And in this capacity, we assume broader responsibility in public health, such as risk assessment, public health education, and disease prevention. As we all know, vaccination is a disease prevention intervention, and it is already practiced by pharmacists. And it is a recognized pharmacy service in countries such as the United States, Portugal, Ireland, Australia, and the United Kingdom. So pharmacy-based vaccination has already been documented to have contributed to increase overall vaccination rates. And this is expected to improve health outcomes of the population. So we will concentrate on countries in Asia and the Pacific and at least learn from our experience how we started it all. Now, the discussion that I will be having with you tonight will be following the policy development process, which I use in teaching a subject on policy. And these are the steps that I have enumerated here, which I think you need to focus on if you would like to engage in the policy development. And the first is to identify the need for a policy. It should have a purpose. Second, identify who will take responsibility. Of course, because this is a very tedious process, it should be identified from the start. And it's very important to gather pertinent information that will be utilized in the policy development process. And the next would be drafting the policy. So it's important that while this is a very big task, a technical working group should be able to draft the policy. And then consult the appropriate stakeholders. You don't want a policy to be rejected by the stakeholders when it is already drafted. So when it is already, approved at the level of the president, and therefore it requires consultation, and you can already discuss differences of opinions concerning how it can be carried out in practice. Finalize the policy based on the recommendations of the appropriate stakeholders, and lastly, to seek approval. Now, let us take a look at how the Philippine Pharmacists Association participated in the policy development process, particularly the passing of the new pharmacy law. This is Republic Act 10918 in 2016, and with vaccination as a component of the new scope of practice. Actually, the whole policy development process concerns the practice of pharmacy in the Philippines, but we have included vaccination as an important component of the new scope of practice. Why? Well, going through the first step in the policy development process, we have here identified the need for a policy. Why the need for pharmacists to do vaccination in the Philippines? Because if you take a look at the top 10 causes of mortality in the country, there are two vaccine preventable diseases, and those are influenza and pneumonia. And we have gathered information that there is poor vaccination rates among adults, and therefore, since senior citizens is one of the identified high risk by Mr. Kim in the previous lecture, it's very important to target them also as the recipients or the beneficiaries of the services that we will be embarking on. The third, there is a prevailing need for educating the public about the benefits of vaccination, and I'll explain that later. And we also have to accept that community pharmacies are strategically positioned all over the country. Remember that the Philippines is an archipelago. It's very difficult to travel from one island to the other. It will take some time, and therefore, community pharmacies can be utilized for vaccination. Number five, there's a need for pharmacists to be recognized as a health professionals and public health advocates. And this we have been battling on for many years. We wanted to be recognized as health professionals. And this is one opportunity. Vaccination is one opportunity wherein we can show that we are health professionals and that we can help them in the and disease prevention interventions. And also, there are already existing practice models in other countries that show that pharmacies can significantly contribute to increase vaccination rates and consequently help in the prevention of diseases and death reduction. Now, the next step in the policy development process to identify who will take responsibility. Now, who will take the process of making vaccination of pharmacies possible? Well, in 2014, when we had the FIP CEO, Luc Besançon, to be our keynote speaker in our convention, we decided to make a courtesy call to the FDA director, and he asked what is the update about the practice of pharmacy. And one of the things that he mentioned was vaccination, and it sparked the interest of the FDA director to the point that he issued an advisory which says that Food and Drug Administration and Philippine Pharmacists Association plan to authorize community pharmacies to administer vaccines. So that means that we were identified to spearhead the plan. And what we did was actually to prepare a concept paper, and that concept paper was presented to the Food and Drug Administration, and they agreed with us that it is really high time for pharmacies to be involved in vaccination. How did we gather the information? Because we are planning to draft a policy in which we will incorporate vaccination in the draft of the Philippine Pharmacy Law. So we actually take a look at the documentation of experiences of countries with granted vaccination authority, and we even look at the outcomes of the practices that they had and whether the population really benefited from it. We also look at the laws and other government policies that are in the Philippines related to vaccination. We take a look at the Medical Act, the Nursing Act, and also the other laws like the Senior Citizens Act, whether they have included vaccination as a benefit, for example. And then we also take a survey of the prevailing views of pharmacists and other health professionals on vaccination. So we really have to do a lot of talking and consulting here so that we are assured that there will be no major barrier among our peers when it comes to the passing of the law and also the implementation of it. And also, we really studied how to develop a policy. So we studied the process so that we will not, we will make sure that we will be able to really make vaccination as part of the law. Now there are we are working with so we drafted the policy. So the technical working group really was from the Philippine Pharmacists Association. But because we are a regulated organization under the Professional Regulation Commission, we have to follow the format that they have recommended because this is the format followed by all other professional organization in making policies, particularly in the in the drafting of a law. Okay, so The next step in the policy development process is consultation with the appropriate stakeholders. So within PPHA, we invited different representatives from clinical, regulatory, and industry groups. So you could see here an enumeration of the pharmacy practitioners, and I have shown you already the 10 affiliate organizations under PPHA where we have their representatives from the different areas of practice. We have patient groups, so we involve people with disabilities, the senior citizens, and also the Philippine Association of Patient Organizations. And we also requested representation from the medical nursing and midwifery profession who at that moment were already part of the vaccination team. And lastly, we invited the head of the National Institute of Health, particularly Institute on Aging, because they are familiar with the needs of the senior citizens. Now, for the regulatory agencies under the government, we have this. We are actually, the Philippine Pharmacists Association is actually a non-government organization. And from the industry, we have representatives from the chain pharmacies because the dominant form of pharmacy in the Philippines are the chain pharmacies more than the sole proprietorship. And then we have the drugstores association. So these are the smaller drugstores, different from the chain pharmacies. And we also have representatives from pharmaceutical companies who actually carry vaccines. So that means that we need to be acquainted also with the products that we are supposed to use in the vaccination. Now, the policy has to be finalized. And this is done in coordination with the Professional Regulation Commission. So they have to check every provision in the draft bill before it can be passed on to the Senate and the Congress. So together with them, we have a copy sent to the FDA and also the Department of Health. So we collated all their input, and from there, we're able to finalize it. And the last part in the policy development process is to seek approval. Now, I tell you, this is the longest part that that actually, I mean, delayed everything because we have to go back and forth to the Congress and the Senate to answer their questions and also to meet some requirements that they need. And then this is sealed with the approval of the president. Once the Congress and the Senate approves the draft, then that will be they will create the final form of the law, and it is sealed with the approval of the President of the Philippines. So the law, RA 10918, or called the Pharmacy Act of 2016, was approved on July 16, 2016. Now, this is the exact wording of the provision in the law that governs the or rather that mentions about the administration of adult vaccines as approved by the Food and Drug Administration. Actually, we did it intentionally that we focus on adult vaccines because we know that it will take a while before pediatric vaccines will be given to non-doctors. So we would rather settle for adult vaccines. And here, it did not mention about influenza or pneumonia, but we expect that in the next step in the policy in the progression of the implementation. Okay, so this one there are requirements. They should have the training on the safe administration of adult vaccines and the management of adverse effects following immunization. So that's a requirement specified in the law, and that they hold a certificate of training by an institution duly accredited by the Professional Regulation Commission. And that's why we as an organization is after the accreditation by the PRC. And at the last part of this provision, the safe administration of vaccines be part of the higher education curriculum for pharmacists. And this really happened. This was made a part of the new curriculum that is to be implemented soon. Now, take a look at how it happened. From 2016, the Republic Act I mentioned was approved at the level of the government for the year 2016 to 2017. The implementing rules and regulations were worked on by the regulatory agencies together with the Philippine Pharmacists Association. And in 2018, 2019, the guidelines, the administrative order, and other issuances were enacted. But during also this time, from 2016 to 2019, there are major activities that were done by PPHA, such as the development of training modules, the training of pharmacists on vaccination. We have level 1. There is a training of the core trainer. Our trainers for the core trainers actually are licensed pharmacists from the US who are Filipino pharmacists, and they are the ones who transmitted, or rather transferred the skills to the core team or the core trainer. And then the second level would be the faculty members of the selected schools of pharmacy in 3 island groups: Luzon, Visayas, and Mindanao. Then after that, the organization, through its pharmacy-based immunization advocacy team, developed the implementation guidelines for pharmacies, which included guidelines for the facility, guidelines for the practitioner, and also guidelines such as those for adverse events following immunization, etc. So there are clinical guidelines, there are guidelines for the facility like the cold chain management, and also for the practitioner with regards to the training. And PPHA also sought accreditation as the training provider for the pharmacy-based vaccination. I put a question mark here: full implementation and monitoring, because as of now, there is a renewal, I would say resumption of the meeting between the FDA, the PRC, and the Philippine Pharmacists Association to really come up with the final guidelines for the implementation of this service. Okay, just to give you some pictures of the training that we had before, and also the you have here the now president of the American Pharmacists Association, who is a pioneer of immunization in the US. So we launched it in 2018 together with the modules and the guidelines. And he is part of the training that was done in other places in Mindanao and in the Visayas. And this is the core group which meet often with regards to the guideline formulation. Okay, so here are some challenges encountered in our journey. There's waning people's belief on vaccination as a result of the dengue vaccine fiasco in 2017, and we have to do a lot of intervention in order to address this problem. There's limited acceptance of pharmacists as vaccinators because this is entirely new practice, and so we need to really influence people and groups regarding this. And there is also a change priorities in programs and plans of action of our partner regulatory agencies due to change of leadership. So we have to there is some delay in the approval of certain guidelines, for example, because of this. And then, of course, limited financial resources. We need more money to support expansion of the trainers' training, while we know that this can be self-funding, but it will take a while. So we need really some investment on this. And the pacing is low as collaborative effort is dependent on various groups' action. So I hope that you recognize that these are the major challenges. So my conclusion is this. Globally, pharmacists have expanded roles in population-based services such as vaccination to promote health and to prevent diseases. The legislation of the law that mandates involvement of pharmacists in immunization through adult vaccination provides a strong legal and policy framework for the practice. And the full implementation of pharmacy-based immunization program would require considerable efforts and resources from key stakeholders and should address the challenges of a new practice. Thank you very much for listening.
Thank you so much, Professor Yolanda, for that rousing presentation. Now speaking as a pharmacy student, I believe that a lot of people here can learn about this journey as well. since within the Asia Pacific arena is actually, and actually most Asia Pacific countries actually, aside from let's say Australia, New Zealand, and the Philippines, most countries don't allow pharmacists to deliver vaccinations. Now, this is something to mull over, and I hope that everyone here will be able to provide like a few questions of their own to Professor Yolanda and to the rest of our speakers later on. But in the meantime, let's move on to our next speaker, which is Dr. Leong Ho Nam. Now, he will actually be speaking about the common barriers that both patients as well as physicians and the current vaccinators face while delivering vaccinations to, let's say, healthcare workers as well as patients. Now, he will also be giving more recap as well as more advice on the current initiatives that have been proposed to increase vaccination uptake. And from there, perhaps we can learn more about what we can do to increase the efficiency and increase the success of such initiatives. Now, without further ado, I'd like to pass my time over to Dr. Leong Ho Nam. Dr. Leong, are you ready? All right.
Hi, just going to check in that my voice is coming out all right.
Yes, correct. It can be heard.
And I need to just turn on my video. I can't turn on my video. We're not turning on the video, am I?
It's fine. It will be okay. Yes.
Okay, that's fine. Influenza vaccination in the Asia Pacific region. I'm really very impressed with what the two speakers earlier have said. Particularly, I'm encouraged by the data that's coming out from vaccinations, as well as the fact that the pharmacists are taking on a role in vaccinations in Philippines. I think that's very good. Now, I've been giving several talks since the COVID-19 started, and I'm just going to show these figures again. The last time I did a slide preparation less than a week ago, there were about 15 million cases. Now, this taken was just today with 17 million cases of confirmed COVID-19 infections with 673 deaths. There's a very fanciful graphics shown, circulated around social media quite recently. And it just goes to show that COVID-19 deaths is going to exceed that of diabetes. So that puts it into perspective, and everyone is stuck at their homes, no travel, and business can't go on as usual because they are begging for, waiting for, asking for the COVID-19 vaccine. And this is the preamble. The preamble will be that vaccination actually saves lives. And this line has been quoted many times. I love to say it again. Apart from the provision of clean water, vaccines have had a more profound effect on world health, especially of children, than any other public health measure. So we all know how important clean water is, and clean water now is available in many countries. Admittedly, there are some places in the world where they can't get clean water. But other than that, the next best thing we can offer another fellow individual, a child, or someone we love, is actually vaccination. But I get very upset, and indeed it upsets everyone, when this opportunity for getting better health is denied because of vaccine detractors. Now, if you look at how vaccines have worked over the years, you look at the 20th century annual morbidity versus that of the 2005, which we entered the 21st century. This is old data, but it goes to show we have eradicated smallpox. Diphtheria in the form of CDC is non-existent. We do have diphtheria in some of the third world nations. In fact, we did have diphtheria in Singapore as recent as 1 to 2 years ago among the foreign workers, working in Singapore. Measles has come down up to 2005, but the cases are mounting again because of the anti-vaxxers group. Mumps, pertussis, polio, rubella, these becomes diseases of the past. When diphtheria struck in Singapore, I was approached for comments on diphtheria, and I say that, honestly, I haven't seen diphtheria. So this tells you vaccines have the opportunity of getting rid of a bacteria, getting rid of a virus. In effect, we are going to live much better. And yet the anti-vaccines have a loud voice in the internet boombox as people, as detractors will just reinforce each other. What's happening to us healthcare workers? Why can't we do that difference? This is just to show you the vaccine hesitancy. It shows the generation at risk. I cannot imagine how many people will be suffering from measles because of the parents' hesitancy. This is taken from cdc.gov/flu. It shows you the number of million illnesses there are in flu hospitalization and flu deaths, and how much of these people can actually be prevented if they actually got themselves vaccinated. Now, acceptance and uptake of influenza vaccines in Asia. This is a nice review paper which is done together in Singapore with KK Women's Children's Hospital, Duke and US Graduate, as well as the Wee Kim Wee School of Communications. If you look at it, I'm going to highlight a few things. It focused on adult populations in Asia, 83 studies in total. Vaccine uptake in Asia was defined as low, and this is embarrassingly low. The exception in Asia Pacific would actually be Australia and New Zealand, where it's much better. And the key points to learn are actually these 2 points that are highlighted. Recommendations from healthcare authorities were influential, which means you as a healthcare worker, you be it a pharmacist or doctor or a nurse, your family members, the members of public will turn to you, and your recommendations make a big difference in convincing someone to take up vaccinations. They look at the general population and healthcare workers. What are you concerned about? Vaccine safety and efficacy. And this is literally all about fake news that's very prolific by the anti-vaxxers group. If you look at the vaccine coverage in Asia among the students and military, we have a large white group of between 4.6 to 83.2, with majority average of about 35.5. And very embarrassingly, the high-risk group, where the people will benefit most, they are just at 37.3%. Healthcare workers, that's yourself and myself, the overall rate, we're talking about 37.6%. General population shown at just 14.9%. In fact, so these numbers are embarrassingly few. Let's try to look at the groups of people who actually refuse to take out influenza, and what's the real reason why some of these people will take out influenza. The first group we're going to look at would be the, let me try to get my, will be the general population. The general population, sorry, my slides are not moving for some reason. There you go. Vaccine inefficiency, inefficacy, as well as vaccine uptake as the main reason cited for refusal of taking out influenza vaccine. But yet, when you look at the people who actually take up the vaccines, it shows you that vaccine efficacy and benefits of vaccines rank as one of the most important reasons. It's very ironic that for the two groups, the very same reason plays on both groups of vaccine uptake as well as vaccine refusal. Then if you look at the immune system, they think they are Superman and that the immune system is sufficient. And however, again, at a high point, high 10 points, the perceived severity of influenza is the reason why the general population takes it up. Very interesting, very contrasting between the two groups. So, and what did I put up on this PowerPoint slide? Just a box to remind you. What's going to help us change between the vaccine uptake and from refusal to uptake is actually recommendations from healthcare authorities. Now, this is another group, which is our high-risk individuals. Again, we see the key points coming up again. Vaccine inefficacy, vaccines unsafe. But if you look at it, the vaccines benefits and the benefits of vaccines are the main reasons why people take up influenza vaccination. This is very interesting. Same points, but on two different camps. Again, influenza is not serious, immune system is sufficient, but in this group, they think that they are more vulnerable and they feel that influenza can be more severe. What does it mean? The messaging has gone through that the immune system for these high-risk individuals are poorer. You need to get influenza vaccination to protect themselves. So messaging did make a difference for this group of people. Okay, again, healthcare authorities, you can make a difference. Now, what about healthcare workers? Surprisingly, these are people on the front line who are best aware about vaccine efficacy as well as safety, and yet they cite the same reasons again. They worry about efficacy of the vaccine and safety. They look at the immune system, you realize that it's not a major issue. Between the two groups, they are quite similar. It's their efficacy of vaccine and safety of vaccine is important. Now, admittedly, in this group of the healthcare workers, they realize that many of them are aware that some of the vaccines have not been very effective in the years 2016, 2017, and 2018. Even as of now, the H3N2 influenza vaccine has somewhat improved, but the efficacy of it is still not ideal. So this has created a mixed messaging. Some people, some vaccines being effective, some being not so effective, and because of the perceived lack of efficacy, then the vaccine is deemed not very good, and they skip getting themselves vaccinated. Again, the reminder: vaccines uptake can improve because the healthcare authorities make a difference in doing the recommendations. And our third comment was this: information is made available most instantaneously in this modern world. Unfortunately, you have both the legitimized as well as the inadequate information sources. Other words, the fake news. The fake news can self-amplify itself. And unfortunately, with the search engines which are looking for, where you look at vaccine efficacy and vaccine safeties, with the right search terms that's posted on by the fake news websites and all the clickbaits, you will in turn end up picking and reading about the problems with vaccines. Now, the other second thing which the authors actually commented was that there were conflicting and inadequate news reports on efficacy, and this resulted in confusion and concern. So we are fighting a war in the internet. And as Singapore gone through the elections and US coming through with their elections, there's going to be a lot more confusion and concern for the elections and certainly for influenza vaccine. And it doesn't help. One particular country that's featured in the news very recently had a lot of vaccine, a lot of mass confusing messages. The leader himself or herself will wear the mask, not wear the mask, and says there's fake news, etc. There's no necessity. So when the top politician, when the top dog at the job refuses to endorse the right information, then you're going to end up with confusing messages that do not help. This here is actually quite a busy slide, and it shows you the different countries with the vaccine distribution, and you can look at it in your own country and see what it is like. If you look at the numbers which Singapore has, it's a pathetic 78.48 per 1,000. Then you look around the other countries. Australia, which is very good at 299.73, South Korea at 335. Take a look at your own countries, and in some cases, you actually have no data available because there was no opportunity or no chance to take the data down. Well, some of the key barriers to vaccination, different countries, understanding different cultural backgrounds. You have India and Vietnam, which cites geography and vaccination logistics. And certainly, we heard about the story on Philippines. There's insufficient or absent public funding in some countries, China, India, Philippines, and Vietnam. Suboptimal surveillance and vaccine effectiveness data, India and Philippines. Lack of healthcare awareness, surprisingly, education for Hong Kong and India. You would expect Hong Kong to do very, very well. the lack of communication of vaccination is a pure problem in India and Philippines, and the vaccine safety. And interestingly, in Australia, Hong Kong, and Taiwan, these are countries which actually have high internet uptake and awareness. Now, addressing the issues of vaccine hesitancy, I will actually direct you to a wonderful article here that's written by Cindy Shen. You can click on the QR code. It takes you directly to the PDF and you can read around it. I think it did a wonderful job, and it looked at the papers available and came up with suggestions on how we can actually improve vaccine hesitancy. Now, one of the things is this. They say practitioners consider focusing counseling on vaccine hesitant parents who under-immunize their children instead of firm vaccine refusers, which means among the people who refuse vaccine, there are two groups. One group who insists of not getting vaccines at all. So in this group, you're going to waste your time as you try to speak to them. Instead, we should actually be focusing on those people who are at risk, who might at risk of not agreeing to vaccine. That means they are kind of in the gray areas. We should focus on them and encourage them. So the other points which they talked about was that physicians remain the most trusted information source. And when they don't have a physician, think about a pharmacist, think about a nurse, think about a healthcare provider. Healthcare providers are the source of information for many, many people. Your vote, your endorsement is extremely important. It is not enough to provide facts and numbers. They actually suggest telling stories. And if you look at it, building trust and addressing pain associated with vaccination. In fact, when you actually tell stories, you want to tell about stories about how influenza killed and affected people, because these stories make a major difference. In the context of Singapore, dengue, for example, one politician ended up having dengue. And that has made such a great effect on dengue awareness and dengue vaccinations. The other way to actually do it is actually to present vaccination as a default approach early on. Don't say, now perhaps we should talk about vaccination. I'll say, now is the time for vaccination. And then we focus on the benefits of protection. And when side effects are being asked, be very honest about it. We're going to give you some examples on this in a short while. So this is approach one, which is suggested by the by the paper. You can click on, you can read the paper subsequently, and you're going to touch about a few things. I'm going to highlight a few strengths about it. Use definitive action words. Today, we're going to give your child the recommended vaccines. They are active and not passive voices. Next thing is recommend strongly, very important. I strongly recommend your child to receive these vaccines today. These shots are very important for protecting your child against serious diseases. And do bring in a little bit of bad news and a little bit of threat. Your child can get influenza, and with that, you can actually end up with encephalitis. Not common, but it still happens at a remarkable rate of 1 in 10,000. Quantify risks and make it relatable. I like to use this example. I say, what are the concerns of the vaccines? You're going to have some pains and aches. What about the rare things like Guillain-Barré syndrome? Then I'll end up saying this story. There's no guarantee that I won't get killed in a road traffic accident when I go home today. But in truth, that risk is really, really very small. But when I vaccinate your child, I'm going to protect your child from life-threatening influenza. This influenza can kill your child, if not even mine, and end up with permanent brain injury. Don't just trust my words. Look at the data, look at the internet. Influenza can kill in children. Now, they also went on through many different kind of questions and how I should answer them. This is actually a table. I encourage everyone to read around it. Certainly, vaccines do carry some risk. The risk overall is very small. We're talking about 1 per million. So my suggestion to you is read around this, be acquainted. You will be asked these questions. Be prepared. It's literally like an exam session. Know these questions and prepare for it. Effect of COVID-19. COVID-19 had certainly an effect. And this is just to show you that when COVID-19 came about, the vaccinations for children came down. This is terrible. I thought with the risk of COVID-19 and people aware of illnesses and infectious diseases, vaccinations would go up. But measles containing doses fell because of this. In part, I guess it was the health-seeking behavior came down. They wanted to delay it. I do hope this will change subsequently. COVID-19 created this immense desire for vaccines. We wanted to go back to normal life. So I do hope this will create a greater awareness of vaccines, that vaccines do save lives. This comes to the end of my talk, and the take-home message in truth is this. We as healthcare workers have an obligation, and this obligation is not just to the immediate people we look after, but to actually spread the message against the fake news that's echoing out through the world about vaccines by the anti-vaxxers. Take this message home. Recommend to the people around you, get vaccinations, get protection. This is the best thing after clean water. Vaccinations save lives. Wissam, I'm going to hand this time back to you.
Thank you so much, Dr. Leong, for that inspiring presentation. I really am impressed, and it really has left an impact on me so far. Now, I believe I speak for everyone when we say that we all have questions to pose to all three of our speakers today, Dr. Leong, Dr. Yolanda, as well as Mr. Kim. So I would rather not spend too much time on myself, and I'd like to hand the time over to our moderator, Mr. Jack Shen Lim, to proceed with the moderation. Now, can I have all of our speakers turn on their camera? Mr. Kim, would that be possible as well?
Yes.
Okay, that's great. And without further ado, I'll hand the time over to Mr. Lim. Please take it away, Mr. Lim.
Hi, everyone. Good evening. Thank you so much for your talks, Mr. Kim, Dr. Robles, and Dr. Honam Leong. It's actually quite a heavy topic we have on a Friday evening, and but I'm going to start off with some questions I have in my mind as I was listening to all these discussions. Maybe I'll relay the first question to Mr. Kim first, because we were actually discussing about one of the reasons why we want to push for influenza vaccination is about the burden it places on the healthcare system. Okay, not only just based on the direct healthcare cost, but on the overall burden that comes with it. Maybe is that something that you can expand on? Because I was reading up on what we need to do here in managing the burden of the disease is quite important. And I think coming from Malaysia, one of the issues I have is people don't realize that they just go around saying that we are in a tropical country, we don't get the flu. Yeah, so maybe passing on to you, Mr. Kim.
Yeah, certainly. So I can talk about Australia and what we did there. So we undertook some modelling to see what the real burden of disease was, because we know that throughout the course of an influenza season in Australia, now we have a population of 25 million, but if you look at the death certificates of people that pass away from flu, it might actually be anywhere between 500 and 1,000 people in a year. But in reality, it is much higher than that, because we know that influenza can bring about a heart attack, for example. It exacerbates other underlying conditions, diabetes and kidney disease, those kinds of things. So the real death rate due to influenza is much higher. So the modelling that we did in Australia shows that influenza kills more people than road accidents, for example. And when you compare those kinds of numbers, people take that on board. They absorb that as something that's worth thinking about. We know that there are 300,000 visits each year to the GP because of influenza. So we know that now through the modelling that of the burden on the health system. So Australia is fortunate that we are a wealthy country, so we can afford to undertake this kind of modelling. But really, that is what is going to be required for each country to actually invest in that kind of undertaking, I think.
Yeah, so from what I gather, I think there is a very strong need for this kind of modeling to actually be carried through in every country in the region, so that we can actually identify more of the burden that it's actually what we see at the surface. We need to go a little bit deeper. Yeah.
Correct. Yes. Yeah. Very, very important. Yeah.
Thank you so much, Mr. Kim. I have a question as well from the floor. This, I think I will open it to the whole panel, but it's more towards Dr. Robles. Okay, I come from Malaysia. I personally can attest to this. Basically, the questions are: how difficult is it to pass a law allowing pharmacists to administer vaccines? And is there a need to hire lobbying groups? Malaysia, we are a country where we don't have dispensing separation, and the doctors do see immunization as part of their domain. And I think this is similar in Hong Kong and Singapore as well. Maybe Dr. Robles, you can have a go at that question.
Well, as you can see from my presentation, it took us 2 years before the law was passed. And you mentioned about hiring a lobbying group for us. We did not do that. Rather, we would like to influence champions, meaning to say you need to have medical doctors supporting you. You need to have some nurses supporting you. It's like that. And then you need to approach also, those non-government organizations that are already into vaccination. Because what we're trying to see here, we're trying to convince them is that when you take us as part of the vaccination team, we will help you in the documentation of persons being vaccinated. Because we have, as mentioned in the report of Dr. Leong, there is poor reporting, poor surveillance. So we said that we need to have a recording system and we will help you with that. So we will contribute to the registry. We also have approached the patients. And we know that patients also would like benefits such as the senior citizens. So there's a senior citizen organization in the Philippines. So if you approach them and tell them about the benefits of vaccination and the convenience of having it in the pharmacy, then they are they would see it as favorable to them. So you earn. So I would not like lobbying groups, but rather people who are already stakeholders in vaccination. Yes, you have to prepare for the long haul because for one, like the Congress and the Senate, the bill which we pass on to them was actually at a transition point where there is election of the national government officials. So our law was passed at that middle. So there are factors that you cannot control and you have to be prepared for it.
Okay. Dr. Leong?
Hi. Can I just compliment? I just want to compliment Philippines again and again and again. The fact to actually push the vaccination down to the pharmacy, that's a brilliant move. I am so proud of you. Now, when I was much younger, I traveled to the States. There I was waiting for my flight to fly from, was it Atlanta or one of the cities, to my exit city from USA. And while I was there was a pharmacist waiting there to give vaccinations. And of course, the vaccinations were free and you could just go there. So when everyone is caught not doing anything else while waiting, that was the perfect opportunity to give the person a vaccine shot. And I am so encouraged by them. So Dr. Robles, I'm just going to encourage you, go down to Philippines where there's a queue, there's everyone's waiting, be it waiting to eat the Jollibee chicken, which I do enjoy very much. Go yourself, get themselves vaccinated during the queue, because every shot you're going to give will help, number one, the person, the individual, number two, help with the herd immunity. And one thing's guaranteed with this entire exercise is the longevity, the better quality of life of Filipinos will just improve simply the vaccination. And I want to chime in on what Dr. Kim Simpson has said earlier on about heart attacks, and I totally agree with him. If you look at it, I always start off a lecture by this and say, who wants to reduce down the risk of heart attacks? And then many people put it up and say, come, go for your flu vaccine because your risk goes down by 50%. And I often quote the Thai people's beautiful data where it says that after the person has a heart attack, forget the fruit basket, because the fruit basket does nothing. If you give them a flu vaccine, you reduce down the risk of a second heart attack by 30%. You give them a flu vaccine, you reduce the risk of a death, be it from heart attacks, from cerebrovascular accidents, you reduce it by 60%. If you truly love the person whom you're visiting, give them a voucher for flu vaccine. If you hate them, give them a fruit basket, especially a durian basket. That's the next guarantee for a major heart attack. So, but one thing is, why do I say there's a problem? We miss apportion blame. When we see a person, our cardiologist will diagnose the heart attack. But Dr. Simpson is most correct. We miss the trigger. The trigger could have been an influenza earlier on. And many of my cardiologist colleagues don't give influenza vaccines. It is a classic face palm moment. Why don't they? Well, do they wish their patients earlier death? I don't understand this. But many of my colleagues do. They send to me to get vaccinations. Now, number one, we fail to recognize that many of these heart attacks are caused by influenza. The cardiologists go in and jam in and treat the effect. The second thing is there is a case of loss in translations. We don't understand what influenza is. When we have the sniffle, we have a bit of cough, we say it's the flu. And hence, I don't want the flu vaccine. After all, the flu is so mild. The truth is, no, that's not.
That's the problem. Yeah, thanks, Dr. Leong. In fact, you actually moved on and answered one of the other questions that came up along the list. It's one of the questions saying that, can we have vaccination as part of the management and treatment protocol for high-risk patients? And I think just to say a simple yes/no answer for the panel, would the answer be yes, we need to have vaccination as part of the management treatment protocol for high-risk patients? Dr. Leong, is it yes?
Yes, it's an absolute yes. So one of the things besides what we can do now is anyone who's discharged from the hospital gets a compulsory opt-out influenza vaccine. Once you get admitted to the hospital, be it for trauma, be it for a heart attack, for a stroke, you get yourself an influenza vaccine. And if you want to get out of it, you have to sign out of it. And to sign out of it, you have to sit into a 15 minutes presentation, absolutely boring. And that will be the best deterrence, okay? Perhaps you can just put one of the presidents of one major country, their speech down there, and then people say, no, I'll get the vaccine instead of watching the video.
Yeah. Thanks so much, Dr. Leong. So, but then there is another question, because there is a group of healthcare professionals, pharmacists, doctors, that has very anti-vaccine views as well. That has also been growing. In fact, in the US itself, they actually, as one of the lobby groups, very, very conservative. I think it's AASP, and they have came out against mandatory vaccination of children. So how would you say, wouldn't it be difficult? This is to all the panelists, wouldn't it be difficult if not all healthcare professionals actually stand by vaccines? Maybe Mr. Kim can start off with that. You know, there is this issue now with healthcare professionals also being anti-vaccine.
Look, that is a very big problem. In Australia, we experience that not to a large degree. It's a very small minority that hold that position. But we know that with social media, there is these rumors and conspiracy theories are spread very easily. For healthcare professionals, we recommend that we find colleagues that are pro-vaccination to talk to those that are anti-vaccination. And as I say, that's a very, very small group. And one of the things that we're trying to introduce in Australia is mandatory vaccination for healthcare workers. So if you want to practice health in a public hospital, for example, you must be vaccinated against influenza. Now that exists already in intensive care units, but it's not yet across the board. But that is one of the solutions, I think. But not many countries are prepared to do that.
Okay. Dr. Leong, this question is skewed towards you now. There's a question regarding, so we have healthcare providers that are anti-vaccine. And so is there any way we can correct HDB misconception of vaccination and efficacy? Any other ways to increase this vaccine advocacy specifically?
Okay, that's a good question. And what I would do is I would look at it this way. Number one, there's a hardcore group that refuses to do vaccinations. And some of them are my best friends. And unfortunately, many of them are neurologists who actually says, I'm going to get a flu vaccine, I'm going to get a risk of Guillain-Barré syndrome. Even if I tell them that your chance is about 1 per million, you have a much higher chance of striking the first prize on the national lottery. And they say, no, I'm still not getting the influenza vaccine. Then I even tell them, you have a 10 to 15, there's about 2 to 3 per million chance of getting Guillain-Barré syndrome from the wild type. They refuse. So I do have couples where the neurologist and the wife who's a respiratory physician, and they quarrel over pillow talk, should get or should not get vaccines. But these groups, you can't convince them. They will say, I will listen to my wife on vaccines. So for this group of individuals which you fail, forget it. They will never take it up. Don't waste time on that. But instead, focus on the group that's in the undecided. You have one camp that's going to go on all the way. You go for the gray zones. So you're going to tell them, get vaccinated. And the way to do it is to catch them on the spot. So number one, as they come into work, go for their meetings and stuff like that, you have your whole tray of various vaccines. You bring the vaccines to them and they can't say no. Then number two, under pressure from the department head, because the department head will have a qualification. You must have, if your department is a poor uptake, your data will be presented out at the meeting and you have to explain yourself why you have such poor data. So the department head will have to be there to take the vaccines and show everyone, I've taken the shot, everyone take the shot. There is no getting around it. And number three, of course, make it free.
Go on. Yeah, so hold that thought. I'm going to have to go to Dr. Robles.
Okay.
It's regarding actually the dengue vaccine controversy. That's this question that came in. Because it has caused a drop in confidence in the whole vaccination program. And looking at diseases like polio and measles may be making a comeback. So this question actually states that as a pharmacist in the Philippines, what action should fellow pharmacists do in order to increase the vaccination rate? And how do we actually go against that rather bad publicity?
Okay, so because truly the government has a big problem during the dengue vaccine fiasco. And so what happened was many people had refused to be vaccinated with the regular vaccines, even for children. like measles. And so there was an increase in the number of measles cases in the Philippines, and there were outbreaks in different places. And so during the World Pharmacist Day, which wherein we devote our time to public health, what we did was actually develop modules intended to influence the to give education to the public about the benefits of vaccination, what are the dangers if you do not get vaccinated, and then we also included their antimicrobial stewardship. So we have a nationwide campaign wherein all the chapters, the local chapters, were actually asked to participate. They were given the modules to lecture, and they were given the instruction to partner with local villages and hold a meeting with the public. And so we were able to do that. And we were very happy that when people have questions, they were able to ask the pharmacist about it. Actually, it's twofold. The people recognize the value of vaccination, and they also appreciated the contribution of the pharmacy. So that means that, oh, we can ask the pharmacist in the pharmacy about vaccine. So that actually opened the way. And also the third good thing about that activity was that our pharmacy leaders were able to partner with the local community. So that means that they have opened the partnership, which will be also helpful for other interventions later on. And because of that intervention, we were able to receive the Silver Anvil Award for the value of our public health intervention.
Okay. Thank you so much, Dr. Robles. I think this question will go to Mr. Kim first. This is a question about dealing with pushing influenza vaccination across the region. And is it, the question actually asks simply, what would the starting foundation of a good surveillance system be for influenza across the region?
Across the region? Well, already we have WHO has sites right across the region, but it is a question of whether the government of the respective countries sees that the importance of reporting incidences of influenza. So in Australia, for example, it's a reportable disease. So, so if a test is done for influenza and it proves positive, then that has to be reported to the government. And so that data becomes available. So really that's the only option, I think, is to have it as a reportable disease and for that information to be collated.
Yeah. So if once we have this information collated, would it make the case of making influenza vaccination mandatory across the region? Wouldn't that resolve a lot of problems if we actually make it mandatory? Maybe I'm opening this to all three of you. I think all of you will have comments on this. What if we make influenza vaccine mandatory, or why is it not mandatory as of this moment?
I think the main, if we look at, again, Australia, where in Australia, there are about 6 or 7 million doses of vaccine which are provided free. There are another 6 or 8 million doses which are available to be purchased. So we have enough vaccine in Australia to cover 50% of the population. But at the end of the day, if you want people to be vaccinated, it is important for the government to recognise the disease as worthy of investing into it. So if the government says, we fund this vaccine because we see it important, people will willingly go and get vaccinated. So I think that's a key aspect.
Dr. Robles?
Well, on my part, I think given that we have poor vaccination rates in the Philippines, I would consider first the high-risk groups to be able to be given these vaccines. As you see, in countries with limited resources, there really is a clear system of how they allocate resources, and so we only have free vaccines for children. And for senior citizens, we have limited coverage. So what I wanted perhaps or wanted to happen in our country is that all senior citizens from 60-year-old and above will be covered by free vaccination, so that that will also improve the outcomes and reduce mortality due to influenza and yeah.
Thanks so much. So, Dr. Leong, I know you have something to say about this.
Okay, I'm going to touch on something a little bit more controversial. And I'm going to discuss this in a very open, transparent way. Now, in Singapore, for example, I want influenza vaccines to be compulsory, but this will never happen. This can't happen. Why? If it's mandatory, if there's any issues, any problems with it, it will go back to the government who made it compulsory. In other words, if you do develop a rare side effect, and then you can actually go up to the court of law and say it is the government's fault because you made it compulsory. Now, if you actually look at the risk for vaccines, the risk is very, very small. Overall risk of Guillain-Barré syndrome is about 1 per million. The risk of actually Guillain-Barré syndrome from influenza is about 2 to 3 per million. So if a child or even an adult who gets vaccinated and develops Guillain-Barré syndrome, either purely because of the vaccine or due to an associated condition that happened then, or due to an at-risk genetic risk because the person already had Guillain-Barré syndrome in the past and you shouldn't have, but the person didn't know about this. So when these things and complications happen, the pointing finger thus goes back to the government, the pointing finger and the need for compensation goes back to them. It makes it really, really difficult. But I know this risk do exist, but the risk is very small. Conversely, I would reduce down my risk of getting other problems and other illnesses. So it makes it worthwhile. To put things in context, if you look at the US data, the most high, if you look at all the vaccines there are, and then there's a compensation and payout for it, which vaccine was responsible for the highest compensation paid out? The answer is actually influenza. There are people who ended up with Guillain-Barré syndrome, extremely rare, but it does happen. And when that happens, they actually sue and there's compensation. Again, it goes down to the example I gave earlier. What's the chance of me getting hit with a car when I go home today? Even tonight when I sleep, or if I go out for supper, what's the chance of me surviving this and this being my last webinar ever? The answer is slim, but the risk is there. But I choose to go out for supper on my own. I choose to cross the road indiscriminately. I take the responsibility. So eventually it has to come down to us to want to do it. And the best way to do it is through you and me communicating the right messages.
Okay, so we do have a lot more questions, but actually, I think it's a good place for us to end this discussion, actually, based on the responses from all three. Because what I took down was, number one, Mr. Kim, it is about funding. It is about getting the funds available. That's one. The second point I got is it's actually about limited resources. That's from Dr. Robles. And so which means that we need to look at targeted responses, maybe high-risk groups first. And Dr. Leong rightly put it, is about safety, or rather the knowledge of the safety of the vaccination, and then leading to personal responsibility over their health. Okay? And the reason why I think that this is the best place to leave off this discussion for tonight is that our students here, you guys need to look into ways to deal with this problem. And I think our three panelists have given you very good tips. Look for funding and how to get it. Look at the targets and which ones matter most. And number three, how to look into improving personal responsibility to be taken up by the patients themselves. Do correct me, I'm wrong, but I think that's a very good place to end. So I would like to thank you very much to Mr. Kim, Dr. Robles, and Dr. Leong as well. Back to you, Rustam.
Thank you so much. I would like to share my screen first, just to. All right. Now, First I would like to convey my congratulations and thanks to all of our speakers and our moderator, Mr. Lim, Mr. Kim, Dr. Roble, and Dr. Leong. Now, it really has been a very insightful discussion, and it actually has brought us to a lot of interesting places. And it was really wonderful to hear the very unique experiences as well as perspectives that each one of you bring. Now, as you have heard today from our speakers today, we actually have a lot of things to consider in influenza vaccination. And our conversation is definitely not ending. In fact, it has just started. So that is why we've actually kickstarted this competition, and we look forward to the participants' pitches as well as solutions that you will give to us on the 7th of August. And before that, actually, I would just like to say that for the questions that have already been submitted, we will be collating it and passing on to the various speakers to get their feedback on it as well. Because I do believe that the questions here hold merit, and if someone has thought of it, the rest of us can definitely learn from it. Now, just to move on to our closing, because it already is time for it around 8:30. So as you've heard today from our speakers, we are living in a time where the message of influenza burden cannot be emphasized enough. The need to innovate for protection against infectious disease goes well beyond our current pandemic environment. Hence, to wrap up our Beyond webinar series, we will be having one more webinar session next Monday on the 3rd of August at 7 p.m. to 9 p.m. GMT +8, entitled The Future of Vaccination. Okay, hold on, my slide is having an issue. Yes. Okay. Now, our speaker for that event will be Dr. Jerome Kim, the Director General of the International Vaccine Institute. Dr. Kim will be sharing with us more on the barriers surrounding vaccination, what have been done to overcome these barriers, and moving forward, what can be done to increase vaccination uptake further. Now, this webinar series is open to all who are interested to know more, and I believe it's a very good tie-up for this entire webinar session. The first one, which was about MedTech, is about the technological thinking as well as how to implement those solutions into the context that you're talking about. And this webinar discussion has potentially kick-started that thinking and questioning of the current paradigm. Now, this third webinar series would like to give you and tease you a bit more about what can be done and what should we look forward to in the future. Now, we encourage all participants to show up during the next and final webinar, as this topic is directly related to the preliminary judging. Now, all of our speakers have shared about the current challenges in increasing awareness of influenza impact and uptake of vaccination in Asia. So as you hack the flu in the next week and co-create innovative solutions, we also implore you to share your opinions with your friends, your peers, and your family, and spread the word for preventing influenza across Asia Pacific. Take the pledge to fight flu and share the hashtag pledge to fight the flu to join this conversation and spread the word to protect against influenza and to avoid spreading it to others. Now, as future healthcare professionals and leaders, by supporting this and joining this pledge to fight the flu, you can share your ideas, findings from the hackathon, as well as pledge to get a vaccine, or share that you have had your vaccine shots done this season. Encourage your friends and families to do the same and discuss this issue more proactively. Together, we can make this preventable burden of influenza a thing of the past. Now, we have come to the end of the session. I would like to thank one more time all of our speakers and moderator, Dr. Leong, Mr. Lim, Dr. Robles, as well as Mr. Kim. And I would like to thank our participants as well for tuning in tonight. And I really want to thank everyone, really. It has been a pleasure to hear about this discussion, and it has been a pleasure to learn so much about this conversation. Now, we look forward to seeing you in our next webinar about the future of vaccination. I am your MC for tonight. My name is Rustam, and it has been a pleasure to serve you today. Now, with that, we've come to the end of our presentation. Thank you. And now, all of our speakers, if you have any other lasting comments, please feel free to chime in. If not, I would not like to hold you back any longer either. Please have your dinner. I do understand it's a bit late. Now, in the meantime, I'll be playing some music. Now for everyone left, we will be closing this room in about 2 more minutes.